excitation, contraction, coupling of smooth muscle. You should already have this drawing. And this is a really important place to sort of study the general facets of muscle contraction. Make sure you understand why calcium is regulating, how calcium is regulating smooth muscle contraction versus how calcium regulates skeletal muscle contraction, right? And make sure you understand calmodulin and its role, and then MLCK and its role here as well, okay? And so I won't go into the steps in detail because we talked about this, but understand how this compares to skeletal muscle contraction in terms of the fact that there's no sarcomere here, right? In terms of the fact that the source of calcium is extracellular as well as the SR, okay? And I hope you all have drawn that table that compares those three types of muscle: skeletal muscle, smooth muscle, and cardiac muscle, and look at the differences, et cetera, et cetera. Okay, any questions on this? Okay, and I think that's all we looked at for, is it? Yeah, for muscle. Mm-hmm.
So calcium still a key driving factor, whether it's applying it on will determine cross-bridge cycling, and then if it's off, it stops cross-bridge cycling, right?
Yeah, yeah. So it's going to bind to calmodulin, and that will turn things on or turn things off. Okay. Where does it bind in skeletal muscle and cardiac muscle? To actin, what part of actin? Troponin, right? Binds to troponin and does that whole shifty thing with tropomyosin, and it regulates that way in cardiac and skeletal muscle. In smooth muscle, it also regulates, but in a different way. It binds to something different, brings about a different enzyme, which then brings about cross-bridge cycling or not, okay? All right. So that was it for muscle. So that's all we did for muscle. That was muscle packet 1, muscle packet 2. And there was a really nice study table at the end that compared single unit versus multi-unit. That's also something that we talked about. And make sure you look at that. Make sure you understand the difference between single unit, multi-unit, and skeletal and cardiac, okay? There are two types of smooth, and there's skeletal and cardiac as well. Any questions on muscle? Okay, now I got a few questions asking specifically about the difference between series and parallel flow, and then asking about some of the valves, right? So I'll discuss those, and then I'll sort of go into some more general things. So when we talk about series and parallel flow, let me see. Okay. We talked about this idea of the heart, the body, which is all of our peripheral tissues, back to the heart, and then to the lungs. This is the way blood flows in our body, and this is a must, okay? Fresh oxygenated blood must leave the heart, travel through arteries and arterioles. Make sure you know this pathway, right? Arteries to arterioles to capillaries. Then from capillaries, we get to venules, to veins, then back to the heart, okay? And then from the heart, it needs to go to the lungs via pulmonary arteries to get reoxygenated, and then back to the heart via pulmonary veins to get pumped back through the circulation, okay? So the question was, how do we differ between series flow and parallel flow? So series flow includes the circulation that must happen. Blood must go from the heart to the body, back to the heart, to the lungs, to the heart, etc. Parallel flow happens when we get to the peripheral tissues of the body in terms of our capillary beds, and blood can go to the liver, some of it can go to the kidneys, some of it can go to the bladder, and so we call this style of flow parallel flow, because all of the blood does not go to each of these areas. The blood splits off here, and we have, say, 20% going to the kidneys, 20% going to the liver, 20% going to the bladder, et cetera, et cetera. And so this style of flow, where the blood has an option, is called parallel flow, versus this flow where the blood does not have an option. This is called series flow. Okay, we also have a bit of parallel flow in the lungs. When blood gets into the pulmonary arteries, half of it can go right and half of it can go left, right? We have two lungs. And so this will also constitute parallel flow. So whenever that blood has an option, right, when it's dividing, some of it can go here, some of it can go there, that is parallel flow, whereas the general circulation of going from heart to body, back to heart to lungs is series flow. This blood does not have an option, right? It has to go through each of these. I hope that made sense. Any questions on that? Okay, so that was series versus parallel flow. The next question that I got had to do with the valves and understanding which valves are where and what they're doing. And so we'll kind of look at this drawing here. So if I can zoom in. Oops. Okay. Just trying to zoom in, but I can't. Okay. So just to describe, we have two semilunar valves and two AV valves, right? The semilunar valves are the valves that are exiting the heart, right, from the ventricle out into the vessel. The AV valves are the valves that are between the atria and the ventricle, okay? On the left side of the heart, we have the bicuspid valve. On the right side of the heart, we have the tricuspid valve. Now, in terms of the general circulation, blood enters the heart through the vena cava, right? This is all of our deoxygenated blood that's coming back. It's going to go through the right side of the heart, the right atrium, the right ventricle, then out through the pulmonary arteries. Here it's going to go to the lungs. It's going to come back from the lungs into the pulmonary vein, back into the left side of the heart, then go to the left ventricle, then out of the aorta, out to our peripheral tissues. Okay, now that happens over and over again. So as far as the location of the valves, we have our semilunar valves that are leaving the ventricles, right, from ventricles to the vessel, whereas our AV valves are going from the atria to the ventricle, okay? And I hope that answered that question. So the location of the valves and then the general flow through the heart. Now, just to remind ourselves here what's happening in terms of what's open and what's closed. During systole, we have ventricular contraction or ventricular emptying or ventricular ejection. Now, what phases of the cardiac cycle correspond with systole? There were two phases that correspond with systole. So we got our four phases: ventricular filling, isovolumetric contraction, ventricular ejection, and isovolumetric ventricular relaxation. So we said what two phases correspond with systole or emptying? Phase 2 and 3, right? So the isovolumetric ventricular contraction, which is phase 2, and then the ventricular ejection, which is phase 3. And so basically what's happening there is that in phase 2, the chamber is contracting. Remember, all valves are closed at this point. This is isovolumetric. The chambers are contracting. That's phase 2. And then in phase 3, the pressure now is high enough in the ventricle that it can open up these semilunar valves, and then we have ventricular ejection. So those two phases, phase 2 and 3, correspond with systole or ventricular emptying, okay? On the other hand, there's diastole, and diastole is ventricular filling. This is where the chambers are accepting blood, and that corresponds with phase 4 and phase 1. Phase 4 is isovolumetric ventricular relaxation. This is where, again, all four valves are closed. The ventricle is now relaxing. The pressure is now falling. And then phase 1, which is ventricular filling, which is where the valves now open. And the valves open because the pressure now is dropped below the pressure in the atria. And so we have this valve opening, and we can resume the rest of ventricular filling. And so those two phases, phase 4 and phase 1, correspond with diastole, which is ventricular relaxation or ventricular filling. Now remember, the heart spends more time in diastole. It spends more time filling. And that's because it needs to fill adequately in order to eject. In order for us to get that adequate stroke volume, the heart must spend enough time filling or in diastole, okay? Let's look at what valves are open and closed down here. So we know that the AV valves are open when the atrial pressure exceeds the ventricular pressure. We talked about this a little bit, right? The pressure is what really creates the valve opening, that pressure gradient. So the AV valves will only open when the pressure here is lower than the pressure here, okay? Likewise, the semilunar valves will only open when the pressure here exceeds the pressure in the vessel, the pressure out here. So the valves here, right, are pulmonary on the right side and aortic on the left side. These valves only open when there's high enough ventricular pressure to actually force these open. This is a passive process, okay? All right, any questions on that? Any questions on that bit? Make sure you understand the phases of the cardiac cycle, okay? I'm not gonna go over them in detail, and what valves are open during each phase. So yeah, both vena cava, we have the superior and inferior, and they're coming into the right atrium. Mm-hmm. Any other questions? Any other questions? Okay. I hope that means that everyone has this down packed and is ready for Friday. Okay. The next thing I will go over, I didn't get questions on this, but I'll just touch on it briefly, is the conduction system here. Okay, and if you have questions on it, you can feel free to point those out. But we talked about the conduction system. Okay, make sure you know that the impulse is traveling from the SA node. It's actually going through the intranodal fibers here. Right, it's going to go through the intranodal fibers, which are part of our conduction fibers. Then it's going to go to the AV node, then the bundle of His, then our bundle branches right and left, and then the Purkinje fibers, and it's going to squeeze that impulse up, okay? Also, make sure you know that the purpose of the AV nodal delay is to ensure that the atria contract fully before the ventricles contract. That's really important. Both atria must contract fully, and then both ventricles contract. Okay, so the sequence of the impulse as well as the sequence of the actual contraction of the chambers. Any questions here? Any questions on this bit? Okay. And I don't think I have any other specific questions or any other specific areas. Are there any specific areas that you guys would like me to touch on, to review? Other than that, I have a few practice questions, which are mostly on the cardiovascular system. But if you have other areas that are still confusing that you'd like me to just touch on or review, I can do so now. Oh, okay, yeah. So in the contractile cell, well, actually, let's look at both. So remember we said that we have two types of cells in our heart, right? We have contractile cells, which are actually doing the work, the contraction. And we have pacemaker cells that are basically just setting the rhythm. They're not so much contracting as they are setting the rate and the rhythm of the heart, okay? And so we looked at the phases of contraction in a contractile cell. And this is basically, before we get into the detail, this is basically what's happening in terms of the channels on a contractile cell to bring about an action potential in this cell, okay? And so when we start out, we start at rest. And this is how a contractile cell is at rest. We said it's a little bit more negative at negative 90. And we have the potassium channels more open than sodium and calcium. And all this means is that we have a more or an increased permeability for potassium, more doors, than we do for sodium and for calcium, okay? And so from that, the first thing that happens is the opening of sodium channels. And so opening of sodium channels depolarizes the cell, sodium rushes in, and that's responsible for generating the action potential, this upstroke. That's phase 0. After that, we still need to maintain depolarization for a little bit. So when we close sodium channels, so phase 1 is closing those sodium channels, this is an attempt of the cell to begin repolarizing. But we do not repolarize right away. We need to sort of delay this process. What did we say was the importance of delaying repolarization in a contractile cell? What's the importance of delaying or interrupting this repolarization? What's happening during this delay? Calcium, right? Calcium needs to get into the cell. And so we interrupt repolarization by opening up our calcium channel and closing our potassium channel. So in this plateau phase, we briefly interrupt repolarization in order to facilitate the movement of calcium into the cell. Calcium is responsible for binding to troponin, right? Regulating crossbridge cycling and bringing about contraction in this contractile cell. Mhm.
So in phase one, there's some potassium in there.
Potassium is still coming in. We haven't interrupted potassium flow. We start with potassium channels open. We haven't interrupted that, right? Good question. Any other questions? Oh, I'm sorry. Is that better? Okay. Any other questions? So that was a good question. So we start off with potassium channels normal. We haven't interrupted potassium flow until phase 2. And this is to stop or halt the repolarization process. And the reason why is to facilitate calcium movement to help get that crossbridge cycling going. When we're done here, we've delayed this enough, right? We then flip-flop the orientation of those two channels. So instead of having calcium channels open and potassium channels closed, in phase 3, we now have potassium channels open and calcium channels closed, and that continues the repolarization, which brings our membrane potential right back down to rest, okay? Because in this phase, we don't have calcium moving anymore. We've closed those calcium channels. And so what we have now is only the movement of potassium. And we know from prior knowledge that potassium is washing out, right? That's ECDF. And so it's going to make the inside of the cell more negative. And so the membrane potential reestablishes back to rest, which is -90 or so. Okay. Any questions on that? I hope that answered any confusion. Was that your question, Tom? Okay. No, it's okay. Yeah, so this was in the contractile cell. Let's take a look at the pacemaker cell really quickly. So in the pacemaker cell, we had a different sequence of events, okay? We had a gradual depolarizing here, a gradual depolarization happening here. We start off at -70. We open up our funny channels, and I talked about the funny channels being mainly sodium channels. So sodium is the main ion that's moving through, in terms of the net movement of ions that's moving through funny channels. So we open up funny channels, and then we close potassium channels. So from rest, right away, we close potassium channels, and that helps depolarize this cell. Now, the excess sodium that starts to accumulate further triggers the opening up of fast calcium channels. And fast calcium channels open, and that's what gets us to threshold. Those T-type, those transient or fast calcium channels gets us to -55. And from there, we further open up calcium channels, a different type of calcium channel here. It's a slow calcium channel, and that is responsible for the upstroke, for the rapid depolarization of a pacemaker cell. Okay, now when we rapidly depolarize the cell, then we close those calcium channels and we open up potassium channels. And remember, we started with them closed, so now we can reopen them, and that facilitates repolarization. Okay, so important to distinguish that in a pacemaker cell, the ion that's responsible for depolarization is calcium, specifically through a slow calcium channel. Whereas in a contractile cell, the ion that's responsible is sodium, and that movement of sodium is the first thing that happens in the cell. Whereas in a pacemaker cell, there's a gradual depolarization.